That are not married and they're doing this incredible.
Well, there's a myriad of things. I think first of all we have to go back to writer. You are very well known for your teaching skills. Your students speak a whole lot about you.
Miss Nigeria competition.
I said, let's pick them up, let's take them back to Nigeria, and let's teach them a different kind of job.
Hello, it's nice to have you join us again on this program, The Woman, where we bring you women who are making marks, cutting edges and smoothing the very rough surfaces just to bring peace for the whole world. Today, I have another personality who is doing just that. She's been on this set before, and that's quite a long time. And as we do, we try to keep abreast of what is happening in the lives of our guests. She's been able to, pick another feather, add it to herself. We'll get to talk about that and what she's doing when we return. And of course, I will be showcasing my guests. Don't go away. My name is Elizabeth Abai.
I don't think in gender boxes at all. I just get on with it.
A man that would dare to ask the wife, who do you think you are? That is a real man.
In fact, our husbands are our firstborns. The husband needs more attention than even the children.
It's not only about work, it's not only about family. They need to take the time to look after themselves, and we don't do that.
They took my money, I paid every fees. I never asked to be hoisted as a governor. I wanted to be allowed to go out there and contest for the position of governorship candidate first.
There's nothing greater than looking back and seeing that while you were aspiring, you were able to inspire others.
Empowered to women. Yes. We need to have more women, multitaskers around Nigeria to get Nigeria working.
Definitely.
So my guest today is one woman who is cutting corners, sharpening edges, rough surfaces in areas of health and even beyond that. She is Dr. Salma Ibrahaim Anas. And if you recall, when I had her first, I told you that she did almost the undoable in Maiduguri, during the time of Boko Haram, when she was Commissioner of Health in that state. She, as well, today has moved on and done so much, still doing so much for women and children. We'll get to talk all about that, but let me quickly say welcome to the studio.
Thank you very much, Elizabeth.
And I must say thank you for coming, because I know your time is really tight, but once it has to do with women, I notice you never say no. Thank you for that.
Thank you. It's a pleasure having you.
Thank you. Somebody was asking me when I was talking behind the camera what you did in Borno State. I tried to share a bit of the experience, but I'm not sure. It's always better when it's coming from the horse's mouth. I know you did something people are still talking about you today. You want to share with us?
Yes. The time I was in Borno between 2011 to 2015 as the Commissioner of Health, that was the peak of the crisis of the insurgency of the Boko Haram. And that was the time that we saw the impact on people, especially vulnerable people, women and children. We had the massive displacement of women. We had the abductions of young people. So we had to quickly organize health services for the people because the need was great, was there. So we had to set up what we call the integrated health services within the internally displaced camps so that people have access to healthcare services, because when such disruptions happen, health is impacted the most. And then you see the weaknesses in health services, increasing burden of diseases, and deaths happen. So we're able to organize that. But I think one most important thing I did that time, because women and girls were most affected, we were able to set up a psychosocial counseling for traumatized women and children. and also try to identify young women that have been abused sexually by the insurgents, and also some other people that took advantage of the situation to abuse women. So we set up such a counseling safe spaces for women and girls that were abused. So for me, it was a great experience, and it was a great learning period for me, because this was the first time I was confronted in my life with humanitarian crisis. And that made me to develop a lot of interest in it. And coming back to the Ministry of Health, I used those lessons learned and experiences to set up the very first humanitarian health sector response crisis desk within the ministry. And that has come to stay in the Ministry of Health.
I'm glad, because your name resounds when it comes to public health, and the much you were able to do there. But I keep wondering, was she not scared? I mean, people who are there at the forefront, your life is at risk, but you were not bothered. You were still doing that. Was there any time you nearly gave up?
Well, to be honest with you, Elizabeth, I wasn't scared. Maybe I was so subsumed in the problems at hand as of that time. I remember you would just see massive number of people displaced and just coming to the city of Maiduguri. And then at that time, even there was no barrier. We're traveling even to communities to see facilities that were burnt down by the insurgents, and immediately to see how we can reactivate and create a substitute services for them. So actually, I was so subsumed in the work, trying to see how we can save the lives of women. And then in that scenario, you can also see women that were pregnant. Wow. Some had miscarriages. Some were so traumatized. So it was, I think we give glory to Almighty God for the protection He provided to us as of that time. But honestly, we're not mindful of where we were, but to ensure that we save lives of women and also children that were so distressed at that time.
Congratulations. And I know that even after you're gone, a lot of work is still going on. And I know you're also still pushing for the health of the people of Maiduguri and indeed the whole Nigeria. And I'm speaking about Nigeria.
Yes.
You are at the moment championing a cause for women. And I was in a presentation that you made, and I recall telling myself, Elizabeth, you need to get upgraded. You were talking about family planning, and yes. I found out I didn't know so much. One of the things you said that got me thinking was that a woman actually had, 11 children? And when you got talking with her, she said, well, I don't have too many. My co-wives had 18, 17. Yeah. Was that story real?
It's a real story. That is the reality. And then I would, before even sharing that experience, I would tell you that the average number of fertility rate for women in Nigeria, as of the National Health Demographic Survey that was done in 2018, still stands at 5.3. It means a woman have a chances of reproducing 5.3 children in her lifetime of reproduction. But this is even the national average. So, but it varies from state to state and region to region. You go to some states and communities, you find a woman can have 15 to 16 children in her lifetime. So that example that I shared, that experience is a reality. I saw it at one of the northern states in Nigeria, where on the average, I visited a home, and I found that the minimum was 11 per woman. A lot of them have between 15 to 16 and 17. But this is a huge risk. It's a huge risk to the women because lives will be lost in most cases. Any pregnancy that goes beyond 4 is a risky pregnancy.
Anybody that has more than
4 children, so more than 4 pregnancies, let me put it that way. More than 4 full-term pregnancies.
So even if I have pregnancy 6 times, but maybe miscarriage or one thing or the other, I ended up with 2. The 7th one will still be a risk?
It's a very risky pregnancy, but I would say 4 full-term pregnancies is a risky pregnancy because the uterus, that is the human body, the uterus, is designed in a way, research has shown that to cater for 4 pregnancies. I always give an example and say that the uterus is like a balloon. When you blow it once, twice, 3 times, it loses its elasticity and becomes flaccid with time. So it's the same thing with the uterus. It carries the baby full time, and then twice, 3 times, 4 times. At the time of 4, it loses its elasticity and becomes flaccid. And then this is an organ that can bleed. So anything can happen at that point. The bleeding can increase, and very difficult to contract the uterus and control the bleeding, which is one of the most common causes of maternal death. And then secondly, the uterus can also burst because it has lost that elasticity. So this is one of the causes of maternal death. But then if you look at it also, when pregnancies are too many, you know, and then too frequent, we've talked about the too many, when they are too frequent, less than 2 years interval.
Okay, I was going to just ask
it also adds a lot of stress to the uterus, and it goes back to the same, affecting the physiology of the uterus.
So these people that do, let me just hurry up and get it done.
Yeah, it's a big mistake. Okay. You know, it's medically wrong. The minimum you can give a uterus to rest is 2 years before it refreshes, it regains its strength, and also the mother's strength and immunity. And
I'd like to get it right. 2 years means if I have a baby now, I don't need to get pregnant until after 2 years, or I have a baby now and wait for 1 year, then get pregnant.
Until after 2 years from the delivery of the first baby.
Oh, so
that is the minimum. We encourage, that is the minimum. We encourage even much more than that, but that is the minimum. And then when the pregnancies, you know, they're not that they are too close, when the age of the mother, she's too young, it's also dangerous to the mother, because that is the time that the girl is growing. She's becoming matured. The organs are growing. And then
so what is the right age for a lady to get pregnant?
The minimum age we always advocate is 18 years.
Okay, so once you're above 18
and above,
okay,
that is the minimum age of pregnancy.
And the maximum.
And then when you are too old, it's also very dangerous to you. So we encourage pregnancies to happen, the best of pregnancies, before the age of 27 years old.
Wow.
Yes.
Wow.
So anything outside that, it becomes what we call the risky pregnancies.
Married at 27.
Yeah, there are peculiar cases, and then a medical expert will have to handle it carefully. That is why you need the antenatal care, a supervised delivery by a skilled birth attendant, and also a very effective and quality postpartum care. So these are the issues. So going back to the issue of family planning that you raised, family planning is a lifesaver, I will put it that way, because it protects the woman from getting pregnancies, and all the issues around the 4 risky pregnancies we talk about, it can be controlled by the use of family planning services and commodities that are readily available. So when we talk about family planning, of which most of people prefer to call it child spacing, or healthy timing and spacing of pregnancy, it allows the woman to have time to take care of herself, give her enough interval of 2 years at least to space the children. So it has been proven beyond reasonable doubt that a woman that uses family planning have a healthier life, and also improved child survival for the children, and the overall family well-being is much better, because she will have much more time to take care of herself and also take care of the children. So this is what we keep on advocating, the use of family planning.
You know, the other thing about family planning is a lot of women actually write on the program asking, which is the best, what do I do? Some complain about certain things, which is why some of us do not go into it. We hear when you do this, your belly, you get too fat. When you do this, you have rashes, you know, hot spasm and all that. I don't know.
Yeah, you know, Elizabeth, what we always discourage women is thinking that you are the same with another woman.
Okay.
We are different, and people react differently. So what works for me might not work for you. And the side effect you have, I might not have such high side effect, because our makeup is a bit different. Exactly. So it's very difficult to say that this is the best. The family planning commodities are all great. They are all good. It depends on the individual woman and what works best for her. You know, ranging from even the natural form of family planning, the withdrawal system, and also the use of oral contraceptive pills, the use of the pills. Now we have the implants that we use in the hands. And there are several of them. So it depends on the individual person. And then you have to try it. You have to go through it with a health personnel, And then you have to go through what we call the counseling to prepare you for it before you accept which one you want to use, based on your choice.
Okay. Now, I'm supposed to be talking about you, but we're turning technical. But I'm sure a lot of women will be happy for this, because it's a question we have always asked ourselves, you know, behind the camera. I would like to know, a lot of times you go to the family planning center, I was told they ask you to come in with your partner. Now, I know that in all of this, apart from the economic effects of having many children, it's a multiple pregnancy as well. It lies more on the woman, where the man does not want to go with you because he wants you to be pregnant, you know, round the clock.
Time, yeah.
Will the health facility still attend to me alone?
Definitely. The health facilities should not discriminate if the woman comes alone. In fact, we're trying to empower women to take decisions on issues that relates to their life in terms of how they want to get pregnancy, the number of pregnancies they want to have, the interval they want to use to space the children. Though we strongly believe, because of our cultural norms and belief, it is a joint responsibility. So in as much as possible, we're empowering women on decision making with respect to family planning. We are also emphasizing on the participation, male participation, especially the partner participation. And that is why you see we encourage them to come with their partners, so that the partners will also be enlightened to understand the risks that are involved with each of these pregnancies and also a delivery. So we try to encourage that, but where it is not happening, we encourage the women to take responsibility for their health. After all, it's about your health. It's about your well-being. You are only a wife when you are alive.
Yes.
If I may say that. You cease to be a wife when you are no more. And who suffers the most? Your children suffers the most of it. So we encourage women to understand, get their partners involved in the decision making, where you have an extended family system, the mother-in-laws, the grandparents, let them get involved and be enlightened in it. So what we try to do is to encourage what we call friendly health facilities that will cater for families, to provide adequate and correct information to enable them make an informed decision as a family. But of course, we are not all the same. So where that does not happen, the woman should not be denied any family planning services. She should be given the right information, adequate information, and enabled to make an informed choice that will work for her, and should be supported with counseling as well.
Okay, so this campaign you're carrying on now, I would like to ask, how are women responding to it, especially the rural women? How are they picking up on this?
Well, I can tell you it's still quite challenging, though we are making some modest progress. But if you look at it in Nigeria, over the last 20 years, the progress in family planning utilization has been very slow. At the moment, our modern use of family planning is just about 12%. And we are hoping to have achieved 27% by now, according to our Sustainable Development Goals. So, but we are now back on track. We try to involve, as I said, it's not an individual decision, but a collective decision. We try to involve a lot of religious leaders, community leaders, by giving them information, empowering them with knowledge so that they understand the benefits, and then the disadvantages of not using family planning commodities. So that is on the part of the community, which will help also women to be able to uptake family planning services. Then on the other hand also, even the health commodities, we try to ensure that they are made available free at no cost. The government bears the cost of it. Government, in support with our support of our development partners, provide family planning commodities free to people, to women, to beneficiaries, if I may put it that way, at all levels of care. Why is government doing that? Because majority of people that requires family planning, women that are vulnerable, they are poor, yes, they are indigent, they are poor of the poorest, they cannot pay for family planning commodities, and it is an essential life-saving commodity. So that is why the government of Nigeria adopted the policy to ensure that we provide quality and accessible family planning commodities to women wherever they are, be it at villages and
there's no
communities.
fear of adulteration, you know how it is.
No.
So how do I know where to go to?
You go to the health facility that is nearest to you.
Okay,
so family planning commodities are available at all the levels of healthcare delivery. At the primary healthcare centers, where majority will go, and then at the secondary level of care as well as tertiary level of care. We are also partnering with the private health facilities to ensure that they also have access to free family planning commodities.
Okay. So, and if you're listening and you're not married, this discussion is not for you. Yes. Here, we preach, abstinence until you say I do to your husband or to your wife. If you're not in that category, it is not for you. But for you, you can actually learn to use it later. I've actually moved a little bit from my usual talk on this set, and that's because this is important to us. A lot of women have been asking, and now you're here. I'm glad we've been able to address it. We'll find time again to speak on it. But I'd like to ask, how have you been able to avert COVID-19 so far? Because I know you never stopped working.
Yeah, we have been working around COVID-19, and we give glory to God that the impact is it's a bit minimal compared to some other countries we are seeing. That doesn't mean that transmission is still not going on. It's still going on, especially among vulnerable people. But what we have done most importantly is to ensure that we guarantee and sustain essential services despite the COVID-19. If you recall, at the beginning, the first phase of the COVID pandemic last year, from April to June, there were lots of fear, there were a lot of anxiety, even among health workers, and that affected delivery of essential health services. And what I meant with that is that, of course, services around reproductive, maternal, newborn, and child health, including care of the elderly people, were disrupted. So, and then family planning commodities as well.
We have more babies.
So we have to really jumpstart and then ensure that we enlighten, we continue to strengthen the health system to ensure that despite COVID-19, we still have other responsibilities to ensure that we sustain essential health services for the vulnerable populace in the country.
Thank you so much. It's been nice having you on the show as always, and our time beats us go, and we must do that. But I must say, keep up the good work. We've been speaking with the specialist in public health whose concern is deep in areas of women, maternity, children, elderly, just as you heard her. And whatever is what, you just heard it, having a number of children at the end of the day does not help us. Children are like visitors in our home. What is important is your companionship, and you need to be alive to keep that companionship with you, with your partner. Do join us again next week. Until then, I'll just bid you to be good citizens of Nigeria. Bye.